Okay. So the first question is 32-year-old patient came to clinic. He has 10 years smoking history. He wants to quit smoking and ask for your help. He explains in history that he tried to quit but was unsuccessful. What is the most important next step you will like to rule out in this particular patient? So if anybody wants to answer this question, no? Okay, so this patient is 32-year-old and he tried to quit smoking already but was unsuccessful, right? And now he came to you and now ask you to help. So before starting, as we already discussed, before starting, you have to rule out what was the cause or what was the problem in past where he tried to quit smoking and was unsuccessful. So before moving forward and asking something else, you have to ask about what was the cause of the failure when he tried before, what was the cause of the failure that he quit, he was unsuccessful to quit the smoking. So you can start from there where he can where he can clearly tell you what was the reason. Was he the craving, or was the social circle, or whatever the problem is. So you can start it from there and help him counsel from that particular part which was unsuccessful. What was the cause of unsuccessful, like in the past. So you can start it from there. So the second question, 45-year-old man came to the clinic with his wife. So now this particular patient is coming with his wife, not by himself. His wife complains that his husband is a heavy drinker. He drinks 30 glass a week and sometimes pass out after drinking. On recent occasion, he wasn't able to attend his daughter's birthday party. What is the next step you are going to do? If anybody wants to answer. Okay, so this particular patient is a heavy drinker and he drinks 30 glasses and he wasn't able to attend his daughter's birthday party. So before starting forward, since his wife is complaining, you are going to ask the husband, particularly if he is aware of that particular condition or not. Since he has been drinking a lot, so is he aware of this situation that he should quit drinking before moving or forward, or before? This is basically a condition which is called pre-contemplation, asking about the awareness of the particular patient, if he is even aware of the condition that he should stop drinking, or he is even not even aware of that situation. So on the basis of that, you are going to start from pre-contemplation, then telling the patient that he has the problem, now he needs to stop it, then moving on to the further where you are going to make the preparation and action, and then moving on forward, all of those steps come next. So this is basically pre-contemplation, and this one is basically unsuccessful. So you are going to ask what was the reason that he was unsuccessful. So those are the two questions coming from smoking and drinking. So these are the questions that can actually touching counseling. So you have to be aware of all those steps which are important. So on the basis of this history, you are able to make or figure it out where the patient is lacking, and from there you are going to start your counseling. Okay, so now we are going to start with the family. So first topic as abdominal, is we covered alcohol, and now coming to the abdominal pain. So abdominal pain is basically you need to know the differential diagnosis on the basis of the not eight, actually nine quadrants. Nine quadrants, you are going to see which particular organ is present at which particular area and where the pain is coming from. So you are able to make the diagnosis that each this area is involved. So that's why the patient is having. If having upper epigastric pain, then maybe stomach is involved, having pancreas problem, maybe liver problem, having all of those conditions, all of those organs which is present over there. So you're going able to make the diagnosis on the basis of that. So this is basically abdominal pain. So you are going to start with the etiology. What could be the etiology? What could be the causes? So GI disorders like having any ulcer, pancreatitis, appendicitis. So on the basis of that, where the pain is, you can easily localize what could be the causes. Gastroenteritis, IBS, and diverticular disease, then biliary tract disease, then urinary tract infection, which will be present in the lower quadrants, then in the gynecological, especially if somebody is a female and in the reproductive age, you are not going to miss the pregnancy, at least ectopic pregnancy, endometriosis, and PID. Then cardiovascular, if having a chest pain along with some upper epigastric pain, so abdominal aortic aneurysm, you cannot miss if a patient is more than 50. So this is written here. This is a very important. If the patient is more than 50, so you have to be suspicious of abdominal aortic aneurysm. its presentation may mimic renal colic or diverticulosis. So first thing first, you have to rule out abdominal aortic aneurysm, then moving on to the renal colic and diverticulitis. That's why we have a screening of abdominal aortic aneurysm, but not a screening of renal colic or diverticulitis. So you are suspicious of that until proven otherwise. This is a statement like until proven otherwise. Okay, that these are the red flags. You have to rule out red flags. How you are going to rule out these red flags, especially in the history. So you are going to ask all of these questions. It's important for NAC OSCE, but in sometimes if they ask you what are the particular questions you want to rule out, so in writing down, you have to write down at least if you know the red flags. So you are the most important questions to rule out in writing down would be these red flags. Asking about something else, this or that or blah blah blah, that is not important. Asking about red flags are very very important when you are asking history. You can miss anything. That's why I tell people who are doing NAC, you can miss any questions, but you cannot miss red flags. So coming to the abdominal pain, what are those red flags? Swear pain, sign of shock, peritoneal signs, abdominal distension, pain out of proportion, new onset of the pain, change in the pain. So altered bowel habits in the elderly. That's why, because altered bowel habits, what could they cause? Cancer. So that's why you have to think of that. Then weight loss could be cancer. Blood per rectum could be the cancer. Anemia, supraclavicular lymph nodes, all of these are basically suspicious of the cancer. Family history of a serious bowel disease, like running in the family history, like ulcerative colitis and IBD, all of these things. Okay. Then coming to the pathophysiology, if you see somatic is basically sharp and localized pain. So on the basis of that, you can easily see which one is particularly present at which one. There is a very nice table on the Google. If you go and see it from there, this pathophysiology will be very easily covered from there. So I will try to send it in the Google, in the group, and then you can see it from there. Differential diagnosis is basically acute viral infection, vasomotor rhinitis. Oh, this is not for this one. This one is for the allergic rhinitis. Coming to the investigation, since in the family practice, all you are going to do is ask about history, ask about doing physical examination, and then moving on to the investigations. On the basis of that, you are going to see if it's GERD, it could be treated in clinic. But if it's something more suspicious or more dangerous, like having diverticulitis, having obstruction, having stones, so now he needs to be seen by some specialist. So after that, you are going to see from there where you are going to send the patient. So basically guided by, investigations are going to be done by after taking physical history and physical examination. That's why history should be very precise, that a lot of questions can be ruled out, a lot of diagnosis can be ruled out in history, and many of the diagnosis can be ruled out on physical examination. So your history and physical examination should be more than enough to tell you what could be the diagnosis. That's why a lot of questions can be ruled out in scenario, whatever they told you in history or whatever they told you, this physical examination is done and now this is presenting. So you can see easily that on the history and physical examination, this is the diagnosis and this is how the patient is presenting. Then what are the tests you are going to do? Since you are going to rule out from the start, CBC, electrolytes, B1, creatinine, amylase, lipase, AST, ALT, ALP, because the liver, bilirubin, then moving on to the glucose, INR, PTT, for the abdominal aortic aneurysm or any other bleeding happening, then come, or INR, PTT also for the liver problems, then toxicology screen, beta HCG. Then moving on to the imaging, chest X-ray, abdominal X-ray, KUB, a lot of things can be ruled out by this one if you are suspicious of them. Then otherwise you are not going to jump to the imaging. Just because you think this is renal colic and you didn't ask any question and you are starting from the imaging, that is not going to help until and unless that patient is coming in emergency. Now you want to do it because the patient cannot give you history or you cannot perform physical examination. Now you can directly jump to the investigation. So this is a little bit, practice is different, where in family history, if the patient is coming to the clinic, the treatment or investigation will start from history, physical examination, then moving on to the investigation. But the same patient is coming in emergency, that patient will be treated in emergency starting from the investigation. Then other test is urine analysis, endoscopy, H. pylori testing done by some specialist or if needed. Okay. Then coming to the allergic rhinitis. Allergic rhinitis is basically increased IgE level, which increase the histamine, cytokines, and local inflammatory reaction. So assessment is basically identify allergens, take an environmental occupational history, asking about everything because it could be allergy. So on the basis of that, then asking about atopic, asthma, sinusitis, all of those allergic reactions you have to rule out along with the allergic rhinitis. So if you're taking about the history of allergic rhinitis and you feel like, yeah, this is particularly, he's telling you, I am having this seasonal problem, I never had this another time of the time life, I just have this in this particular condition, I have this, and you are suspecting of allergic rhinitis. So what other conditions you need to rule out, ask about related. So they are clearly saying that you have to rule out atopic dermatitis, asthma, sinusitis, and family history. So if the patient is coming with allergic rhinitis precisely, you have to ask about these conditions as well. Okay, so don't forget about these ones. These ones come along with this particular disease. Okay, then coming to that management, starting from non-invasive ones, which one are those? Conservative, and then moving on to the pharmacological. What are non-invasive ones? Most important is you are going to counsel about the lifestyle modification. Lifestyle modification: avoid the allergen, avoid, wear mask, take this, do hand washing, hygiene, and nasal saline, rinses, and everything like that. Then moving on to, if the patient says, I have already tried every single thing, now what should I do? Then you can prescribe antihistamines. Okay, first line therapy would be antihistamine. But first thing first, if he's having a mild problem, then you can talk about this conservative. But he said, if I have already tried it and nothing is working for me so far, so then you can move on to antihistamine first line. Then you have to see, because antihistamines are of two types: one that causes drowsiness and the other one that doesn't cause drowsiness. So you have to see this particular patient, which one she needs or which one he needs. Because if he's working in the daytime, he said, I have working in, like I have to go to clean, I work in some environment, I cannot take some drowsy medicines, right? So on the basis of that, you have to see which particular medications you are going to see. So it's very important you know which ones are antihistamine drowsiness or which one is not. Okay, and then moving on to the next one, if he is having a moderate or severe allergic rhinitis that is uncontrollable with antihistamines, then now you are going to move on to intranasal corticosteroids. So what are the situations in the severe or moderate where he's having sneezing it too much, where it's like he is not able to breathe, if he is having this asthma, eczema along with it, or along the conditions, this is like very high conditions going on along with it. Okay, then moving on to the next, which one we can do is intranasal decongestant, which is not used, because if you use it for less than, it could be used in less than 5 days, but if you use it more than 5 days, what could happen is rhinitis medicamentosa. So you need to know which drugs causes rhinitis medicamentosa, intranasal decongestant. So that's why it's kind of avoided. Then moving on to the next one is allergic skin testing. So you are going to see if the patient is particularly, if you cannot rule out what is the cause of that for particular allergy, okay, then you are going to do it. Otherwise, you are not going to do this. This is not particularly done in normal cases. Like for patient with a chronic whose symptoms are not controlled, so this is written. When are you going to do chronic? Symptoms are not controlled by conservative and pharmacological therapy. Now you have to move on to the next step where you are going to find out that particular allergy and ask the patient to stop being exposed to that particular allergy. Okay, may identify allergens to include in the immunotherapy treatment, and moving on to the immunotherapy. When everything fails, now the patient needs something which is like for long time, severe cases, unresponsive to pharmacological, like you couldn't find out anything, you couldn't do anything about it. Now the patient needs something which is for the long period of the time, which could be immunotherapy, or the patient cannot tolerate these medications, so then you can move on to immunotherapy. So it is very important, they will give you in the scenario what they want to listen. So they will already told you that if they want a conservative, that this is the first time he is coming, now you're going to talk about conservative. Now he is coming again, he already tried the conservative and it fails. Now you have to move on to the histamine. Now in the histamine, the patient is particularly pregnant. Now you need to know which histamines she can take. Now the patient is working in an office. Now which histamine he can take. Or the patient is not working, but a child. Now which histamine he can take. Or if he is in a moderate or severe condition, now he need to move on to intranasal corticosteroid. Or if he has tried every single thing and nothing is working out so far, so now we are going to do it allergic skin testing. So this is very important. They will tell you with one line, it will be very easy for you to get into the which management you are going to do. Then coming to the next one, symptoms of the generalized anxiety. This one is the anxiety is the next topic. So they have written down what are the generalized anxiety. They are written very nicely, and I see rest. Conscious, when the patient is anxious and nervous, worried, so having this anxiety feeling all the time, at least the duration. In the psychiatry, the one of the most important thing is remembering these duration, because if the duration changes, the diagnosis changes. So that's why this duration is important. So generalized anxiety comes after more than 6 months, then irritability, concentration, restlessness, energy, sleep, and tension in the muscle. So differential diagnosis is written nicely here, which could be the differential diagnosis of anxiety, like having panic attack, phobias, agoraphobia, specific phobia, selective mutism, and separative anxiety disorder, or other disorders. All of them you have to rule out along with psychiatry if there is any clinical problem going on, any systemic problem going on, like cardiac, endocrine, respiratory, somatoform disorder, psychotic, mood, personality, drugs. So you have to rule out all of these ones. Then moving on to the next one, this one is along with the asthma, we will do this. Then here, symptoms of anxiety, this is very nicely a very nice table. You can do it from here and then go to psychiatry and do psychiatry from there. So moving on to the anxiety, if the patient is having those unconscious feelings, having anxiety, having tension on the muscles, and he couldn't figure out what is the cause, so on the basis of history we are going to ask what could be the diagnosis. So what are we going to see is in the form of panic. Is it coming in the panic form with a physical stimulus, like if he's doing something particularly or in a particular environment, if this particular thing happens, so come do the panic attack come, like if it comes for 5 minutes and then it goes away by itself, or it is like a it stays there and he worries about every single thing. So this panic attack has like attack situation. Attack means like it stays for some time and then it gets better. Okay, so this is basically attack is basically a phase. Now we are going to do is with a specific situation or out of blue, like he was sitting and suddenly start happening. When you sitting down, especially it happens to female, she's sitting down, start thinking of something and then it start happening. With a specific situation, something, a female is sitting down in the office and a boss appears, or if some particular person appears and he sees that, or some particular situation created in that particular environment, and that female or male start getting panic. Okay, so now on the basis of that, if it's coming with a specific situation or is it out of blue, so on those two bases you are going to see if the patient is avoid. If the patient is avoiding, then it's basically phobia. If the patient is afraid that another attack comes, so now panic attack and panic disorder, there are two different things. Disorder is when somebody is aware of that he is having this panic attack and he is definitely trying to avoid that particular situation. Now this is basically becomes panic disorder. Okay, now this patient is avoiding the situation, yes, then it is phobia. Like if somebody is afraid of something and trying to avoid it, right? So this is basically a phobia, like specific triggers, specific phobia, like with the spiders, with the blood, or all of those things. Then coming to the social phobia, when people doesn't want to go out, just want to stay isolated, mostly like introvert people. They don't want to go outside and do negative, like they feel like somebody is looking at them and judging them, so they try to stay inside. Then moving on to the next one, which is basically panic disorder with agoraphobia, where they try to escape, like setting, like having this let's suppose he is in a bus. Okay, and where they feel like there is a lot of people and he couldn't escape from that particular situation. So this panic disorder becomes with the, because now he is having this disorder along with this agoraphobia. Sometimes agoraphobia comes alone as well, but it's not important. So sometimes a panic attack or panic disorder along with agoraphobia, so he doesn't he particularly doesn't go by bus. So it is very common in Canada. A lot of children suffer from this condition. Then moving on to the next one is basically secondary to the specific experience trauma, where somebody has an experience trauma. If it is less than 1 month, so a lot of patient, like people, they don't know what is the difference between acute stress and PTSD. So it is very important that both have the same experience trauma. But if it's less than 1 month, it is basically acute stress reaction. Then if it's more than 1 month, it is PTSD. But this PTSD can come after 3 months. After that particular situation happened, there is a gap between 3 months, 6 months, whatever the gap is, and now it start happening, and it's happening for more than 1 month. Now this becomes PTSD, not happening for 3 months, but more than 1 month. But the gap between that, this is just like how soldiers go to war and they came back and start having this kind of PTSD after in the later period of their lives. So the war they attended and the situation started, it is a very time lag between them. So that's why PTSD has a big time lag. but it started, but the symptoms should persist for more than 1 month, then it is called PTSD. Okay. Then moving on to the next one is recurrent anxious thoughts, excessive worry and apprehension about the common concern. If it's less than 6 months, then it's basically adjustment disorder, where the patient has moved from one person place to different place, and now he's trying to adjust it with the, like, how female moves to the new place and living in the hostel, right? Then moving into a new country or moving to a new place. So this is basically where they are having the situation, and it should be less than 6 months, then it becomes the adjustment disorder. But if it's coming more than 6 months, then it's basically generalized anxiety. Now she's panicking about every single situation, not just for the living, but she's panicking about every single thing. Like, anything happened to my child, anything happened to my husband, anything happened to my mother, like anything is happening, she's just panicking for no reason. Okay. So now this is basically generalized anxiety. Now moving on to the next one, where the apprehension and the common concern are thoughts intrusive. Now coming to the OCD, where the patient is having these thoughts, and if we don't do it, he start feeling anxious. Now, like, my hands are dirty, if I don't wash them, I start feeling like anxious. So this is basically OCD. So there are personality disorders that you need to know the difference between the disorders and the personality disorder. And it is very nicely written in psychiatry. When we will do psychiatry, I will tell you, because psychiatry is something very, very easy, but hard to build up the concepts. Okay. So then moving on to the next one, it would be like having the same situation could be also affected by the social phobia. This is a very, very nice table of all the generalized anxieties or all the anxiety disorder. You can easily remember it from here and then go to psychiatry and read it from there. This is such a nice table, and it is very easy to, like, everything is comprised in this nice table, so you can see it. Okay. How are you going to manage? First thing first, you are going to educate, you are going to tell the patient that what kind of condition she is suffering from, emphasize prevalence so she can be aware of what is going on along with her. Okay. So telling her about her situation is the first thing or first goal of treatment. Then that has a good recovery rate. Okay. Then moving on with the context, explore lifestyle habits. Like if she's having too much caffeine, that is also feels like you have panic attack, like palpitations. Then exercise, caffeine, alcohol intake. So you have to ask everything in the history, along with maybe the diet is the problem. She's taking something like alcohol could be the problem. Then collaboratively develop a person-centered approach. Like you have to talk about where she has to stop taking caffeine or at least reduce taking caffeine, do little bit of exercise. How, what kind of exercise? Like you, those mindful techniques, breathing exercise, yoga, tai chi, all those music techniques, like all of those techniques she can use. This is basically those exercises are basically mindfulness techniques. Then coming to the psychological, where she has to go to some psychologist or some therapist, where she is going to and go and talk about all of this situation. So this is basically called CBT. Exposure therapy, where that particular situation or scenario is going to put into that particular patient. So we are going to see how she is going to react. So this is basically exposure. So if you're going to keep on exposed to that particular situation, she will slowly stopping it down. Then relaxation, those breathing techniques, music, water, a lot of techniques, mindfulness techniques, breathing techniques, all of these mindfulness situation strategies, where you have to put the mind into something else so patients stop thinking of that thing. Then pharmacotherapy, it's written in psychiatry, offer self-help materials, connect with the community, support groups, provides support to the family and caregiver. Anybody has any question up till here? No? Okay. Then moving on to the next one, asthma and COPD. Asthma and COPD, you need to know the difference between asthma and COPD. We have been reading this asthma and COPD for so long, but a little difference here in Canada, which is basically asthma, and COPD is basically where we are going to know which treatment or which investigations we need to do. So after one thing that I want to mention here, you need to remember all these precipitants. What could be the precipitant of COPD and asthma? History of allergen. Okay. Then moving on to the, obviously, if you remember all of this, it will be very easy for you to build up the diagnosis of that patient of the scenario. Then moving on to the next one, which is sign and symptoms, where you need to see what kind of symptoms it is going to present with the asthma and COPD. Sometimes they particularly mention that this is asthma kind of situation, that he's already have this history for so long. So now you are seeing that this is asthma, but sometimes they say this is now it triggered out and now this is happening. They don't give you a line where they say this is happening for so long. So you are not able to differentiate between asthma and COPD, or you have to see how does the x-ray of the particular patient of asthma and COPD looks like. So go to Google and find out how does the x-ray looks like. So on the basis of that, you need to find out and make sure you know what kind of other situations could be associated with asthma, or maybe differential diagnosis. It is very important as well. Then what kind of symptoms? It is wheezing, dyspnea, chest tightness, prolonged expiration, cough which is worsened in the cold at night and in the early AM. So then moving on to chronic. Chronic is basically cough, sputum, and dyspnea, like having those bronchitis, acute bronchitis, and emphysema. So those two presents with it. Then diffusion capacity, hypoxemia, spirometry, you can read it. Then a chest x-ray, how does it look like? More easily if you go to Google and see how does it actually look like. Then management, we will conduct a class where I will try to put all the x-rays together and see it one by one, okay, so that everyone can see how does the x-ray will look like, okay, every x-ray of all the diseases. Then coming to the management of the COPD, first thing first, you are going to talk about smoking cessation. If the patient don't stop smoking, the condition is going to keep on getting worse, so you have to counsel about the smoking cessation. Then if the patient is mild, you are going to start from the SABA, which is going to be parental route. Then SABA plus LAC. If the SABA is not unable to control it, then moving on to the LAC or SABA. LAC is basically long acting anticholinergic. Then moving on to long acting beta agonist. And if the patient is moderate, three drugs will be added. Say, as you can see, step 1 is 1 drug, step 2 is 2 drug, step 3 is 1, 2, and 3 drugs. And inhaled corticosteroids can be considered, but remember that COPD has no good effect of steroid, but in asthma is totally different. This is basically SABA. SABA is patient is taking it already as a rescue drug. So you need to know which one is rescue drug and which one is maintenance medication. So it is kind of important which one is rescue drug and which one is maintenance. So SABA, he's already been educated in environmental control because he has a history of it. So he is being told about that. Since he's coming again, you are still going to start from the education and environmental control. Even though he knows it, you are still going to start from the very start, which is basically education and environmental control. Even though he already knows it, but our first goal is telling about that. Then he might be already taking it SABA. If not, then you are going to start from the SABA. Then maintenance medications. What are the maintenance medications? These are the maintenance medications. Step 1, you are going to start with the inhaled corticosteroid. Now you can see in asthma, you are starting from inhaled corticosteroid, but in COPD, you are starting from SABA because this patient was already taking SABA. So now we are going to add SABA into, SABA plus inhaled corticosteroid. Now, if he is not able to control it, what are you going to do is increase the dose. It is very important to remember these management because COPD is different than asthma. A lot of people mix it up. So that's what I'm saying. You need to remember them. Okay. Then next to the increasing the dose, or you can add the leukotriene receptor antagonist modifier. Then the step 3 is where you are going to increase the dose along with either LABA or either leukotriene receptor modifier. And it is particularly started after 12 years of the age. It is written in respirology, not here. So when we do respirology, I'll try to mention it there that after 12 years, you are going to increase the dose or going to add up one more drug into that, or either starting leukotriene receptor antagonist after doing everything before the 12-year age, or after 12-year age, you are going to start it right away. Okay. Then along with it, you are going to talk about the immunotherapy, glucocorticoids, where he can take oral glucocorticoids. Then moving on to the which one? Pneumococcal vaccination and annual influenza immunization. This is basically family practice of asthma and COPD. Emergency practice of asthma and COPD is totally different. Okay. So don't complicate it or don't mix it. Remember the family one and then try to remember the emergency one, because emergency one is little different. I won't say totally different, but little different how you are going to approach that particular patient, because we start from A, B, C, and then moving on to see what patient needs. And along with that, we are going to add up the therapies. And over there, we are going to start, maybe we need IV, maybe patient need to be intubated, right? So their approach would be different, and here the approach is different. All of these are going to be give parental nutrition, oral, inhaled, right? Not anything is not given IV, because in clinic you cannot give anything IV. Patient is sitting down, you are sitting down, how you are going to give IV? Writing down in clinic you are giving IV is totally wrong. Okay. So this is the signs of poor controlled asthma. Beta agonist use of more than 4 times, asthma related absence from the work, school, and night, and symptoms from more than 1 week, and exercise induced asthma. Okay, so that's it for today. We'll try start from here. Anybody has any question from here? So try to remember it from here, and then when we are going to do emergency, I'll tell you what is the difference between family and emergency. Because if I tell you right now, you will just confuse yourself and it will be hard. Okay, anybody has any question?